testicular tumor in male genital system. So male genital system is composed of, it's a reproductive system composed of testis, epididymis, penis, scrotum, and associated with the vas deferens, prostate, and seminal vesicles. But all the structures are not so important for you, but the testicular tumor is important for you, and that penis that are for short note for exam purpose. Testicular tumor, seminoma of testis is for specimen, and the related question they will ask in the oral examination, sometimes explain why, that also they ask. So we will proceed today. What are the diseases are coming from the testis? That is the congenital abnormality, that is the cryptorchidism or hidden testis or undescended testis. That is very important because they are vulnerable for testicular tumor. So undescended testis, developmental defects that are very important. Testicular tumor, then any inflammation of the testis, epididymoorchitis, that is important. Other torsion, hydrocele, pyocele, many things are related things. So more important things is the testicular tumor. Same way the prostate also is already you have studied, I think. Prostate is prostatitis, and the hyperplasia and neoplasia of that prostate, that is the benign hyperplasia of prostate and prostatic carcinoma. And the lastly the penis, phimosis and paraphimosis, and the carcinoma of the penis. These are the disease entities in gist. Now, this is the normal structure of testis. This is a normal thing. And here the structures, that is the testis, seminiferal tubules. These are the spermatogenesis. This is the epididymis. These are the composed of these are seminiferous will give rise to radiotestis and ultimately give rise to a vas deferens. This is a alternate structures of this thing. Now diseases of the testis. What are the diseases that can occur? Usually is benign and neoplastic. That is the benign orchitis, epididymoorchitis, maybe hernia, hydrocele, maybe torsion, maybe STD, that is a sexually transmitted disease, hydrocele, pyocele, hematocele, and atrophy of the testis and the cryptorchidism, undescended testis. These are the some nutshell. Now testicular tumor. So many kinds of tumors are there. This is the testis. Some are totally effaced, some are localized, some are that hemorrhage, necrosis, some are these variegated pathogens. So that there are various types of testicular tumor of various presentation. And the microscopy of the common one is the seminoma. This is the microscopy you can get. But there are tumors, but for your exam purpose, only one thing is the seminoma of testis is very important. You have to answer all the questions related to seminoma. All the tumors are not for exam in AUG, but it is for the PG. But you concentrate on the seminoma testis, and nutshell of the classification of testis. Don't know the in exam may ask sometimes, but you have to read that thing how to classify thing. Now testicular tumor, it is an 1% rarely tumor, but 1% of the cancer death. Usually occurs elderly, but it can occur in the infancy, in the early adult, or in childhood, and in the elderly age group, that is more than 60 years old. The peak incidence in the neonates, maybe in the early adult or in the old age. So every that can occur in this spectrum. And the nutshell of this classification based on this WHO 2022 depends upon the structure of origin. That testis is a site for spermatogenesis. So this tumor arises from the two separate entities. One arising from the germ cells, that is the 90%. Another part is the 5% is the stroma. So tumor is a germ cell origin, and another is stromal origin. This is the two broad classification. If it is germ cell neoplasm or precursor seminiferal tumors, are 5% is said for stromal tumor. Maybe other stromal cells, that is the lytic cells, subtle cell, the tumor arising from that. And clinically, these testicular tumor categorized in two broad classification. Why they categorized into seminoma and non-seminoma? Why it is? Seminoma is radiosensitive. So treatment outcome is better than non-seminoma. So clinicians, they only their asking question is it a seminoma or non-seminoma because of management. Yeah. Now, what is the etiological factors of the testicular tumor? It may occur in the developmental defect. It may occur some germ cell neoplasia already exist in there, or it may be a genetic defect, or some carcinogenesis are exposed to that patient. So, developmental defect, what are those? So, gonadal dysgenesis, maybe a cryptorchidism, maybe undescended testes, maybe a hormonal insufficiency, that is the Klinefelter syndrome, Marfan syndrome, Down syndrome associated with these things, or the patient is exposed to some genetic disorder, that is that aneuploidy, amplification of this chromosome 11, 13, 18, 12 chromosome mutation where TP53, cyclin D, E, first gene, BRCA1 gene, these are the genetical factors responsible for this carcinoma of the testes. And carcinogenic agents are patient is exposed to that is a radiation exposure, maybe in trauma, maybe the endocrine disabnormality, or maybe a drugs, that is the therapeutic purpose, may predispose to this thing. Another thing is the environmental factor alone with this are the some responsible factors for origin or the development of the carcinoma of the testes. Clear? So, this clinical feature, how they presented this thing? Clinically, patient presented with a mass, dragging pain in early stage. If patient presented with the late stage, maybe a features of metastasis are there, that is maybe malignant metastasis, maybe distance, maybe in the lung, maybe in the brain. So, depends upon the stage of the disease. If it is early, so it is a localized symptoms. If it is a late, that is the features of metastasis, they will present. That is the clinical feature. Then how they spread? Both lymphatics will come in details later. Lymphatic spreads and rheumatism, so all are follow the testicular tumor. Now, diagnosis, how to diagnose a testicular tumor? Apart from the routine examination from the tumor, you have to do the ESG, CT guide or MRI, and CT guided or USG guided or MRI guided cytological aspiration, that is FNAC, or biopsy for better outcome. And why it is needed for this extensive? Because of the spread of the disease, how far they spread. The FNAC can diagnose by this is a localized diagnosis, but how far it is a metastasis or the spread of the disease, so you have to do the USG or CT scan, PET scan, MRI for investigations. Now, the other things, molecular testing is the 12 chromosomal 12 amplification. I will come later why this is important, because the tumor is classified as germ cell neoplasia in situ and non-germ cell neoplasia in situ. If it is chromosomal 12 amplification positive, it is associated with the germ cell neoplasia in situ. If it is negative, non-germ cell neoplasia in situ. There is a broad classification into this chromosomal 12 amplification. Positive, it is related to germ cell neoplasia in situ. If it is negative, non-germ cell neoplasia in situ. So, this is very important. Other serum markers or tumor markers depends upon the composition of the tumor from the classification. That is that if it is Yorkshire tumor, that is alpha-fetoprotein. If it is lactate, then Beta-hCG, it is a cholangiocarcinoma associated with this. So, depend upon the composition of the tumor, that tumor markers also we expect from the molecular examination. So, this will help for treatment purpose. If we get that tumor by biopsy, after that we have to do ISC. Because of this ISC marker positivity, the clinician will treat accordingly the secreting of the tumor marker. So, these are the diagnostic features. And then, so prognosis, how will expect the tumor is good prognosis or bad prognosis, depend upon the tumor size. If it is a small one, good prognosis, a large one, better prognosis. If it is a due to metastasis, is a very bad prognosis. Other things, lymphovascular involvement, then lymph node metastasis, then hematogenous metastasis. These are the some factors. Seminoma is very important because it's a radiosensitive and good outcome than other tumors. That is the 90% of the cure rate. And non-seminoma, that's why we broadly classified into seminoma and non-seminoma because it is radio resistance. So this is important and more aggressive and poor prognosis. So testicular tumor, there are chromosomal 12 amplification positive associated with the germ cell neoplasia Situ, negative non-germ cell neoplasia Situ. If it is seminoma, it is a radiosensitive, very good outcome. If it is non-seminoma, it is a bad prognosis and early metastasis. And if it is a post-pubertal, tumors classified into pre-pubertal and post-pubertal. If it is a post-pubertal, these are almost malignant and it is an aggressive behavior than the pre-pubertal germ cell tumor. So these are the nutshell for oral purpose. For understanding, you know that. In exam, nobody will ask in the theory question, but in oral question, if you answer very good way, that examiner can ask to you. Now, it's a previous classification for understanding purpose. For better enumeration is this is classified into germ cell tumor and tumor that I told earlier. Under germ cell tumor arising from the one histological and other more than one histological, that is a mixed. Under this seminoma, non-seminoma. Seminoma is the seminoma, spermatocytic seminoma, and non-seminoma, embryonal carcinoma, Yorkshire tumor, choriocarcinoma, teratoma. And the stoma is a lytic cell tumor, stromal. For understanding it, too easy to remember, that is a previous classification. But now that WHO 2022, they are classified as a very big classification. Only to know that is a one big classification, they are under WHO 2022. For exam purpose, for oral purpose, you remember the short classification. It's a short one, previous one, only for understanding. This is the primary one. What are the secondary tumor coming is that if that examiner asks in the theory, primary tumor, secondary. If it is primary one, but unless you write that secondary one, the answer will be incomplete. And so secondary tumor is coming from the other distant side. So that for exam purpose, for completion of the answer, the secondary tumor will be the another line for that. So primary, under all those things, germ cell tumor, stromal tumor, and the secondary one coming from the distant. So for completion purpose, these two heading under this primary and under this secondary. Clear? Now, another classification, that histological classification depends upon the 12, that is chromosomal 12 amplification, positive, negative, that is associated with germ cell neoplasia in situ, non-germ cell neoplasia in situ. শুধু মনে রাখবে, জানো যে এই জিনিস আছে, পরীক্ষার জন্য দরকার নেই। যদি কেউ তোমার এমসিকিউ বা কোনো কিছু দরকার লাগে, রুটিন পারপাস মনে রাখা না, শুধু জানো দুটো এন্টিটি আছে, germ cell related arising from the germ cell neoplasia in situ, another is not associated with the germ cell neoplasia in situ. Because of the treatment purpose, they have classified in two due to the chromosomal 12 amplification. Positive is this side and the negative is, this side. So this is a two thing. It is occurs in the elderly early age group and associated with this 12 amplification, expression of the marker is of 3/4. C-kit, another tumors are seminoma and another non-seminoma. This is all post-pubertal, and is that they are negative, they are lack of 12 pre-chromosomal amplification, but composed is the teratoma, Yorkshire tumor in the pre-pubertal type, it occurs in the young age group, and older age group, this is pseudocytic seminoma. All is forget the things, but for understanding, for treatment purpose, clinician they divide these things for treatment purpose. Say WHO 2022, we will not go in details, only know that is advanced classification they have done by WHO. We will not go, but the heading is as germ cell neoplasia associated with the in situ, not associated with the in situ, stromal tumor and the hematolymphoid tumor, another classification they added. So don't know not need to remember this thing, only you know that is what classification is same from the previous classification for treatment purpose and management purpose. Not going is this, a testicular tumor related to germ cell neoplasia in situ, not arising from the. Now for exam purpose, this is important, only you know the seminoma of testis for important because of maybe coming the short note, maybe in the specimen, and for oral purpose different types of questions they will ask from that specimen. So seminoma you have to know in details. So it is in normal structure, gross. This is a normal seminiferous tubule. This is a tumor, well circumscribed, maybe a hemorrhage, necrosis, lobulated, bulging from that tumor on card surface. So seminoma. This is the common tumor of the all testicular tumor. Usually counterpart they will ask in the exam. What is the counterpart? আমি কি করব বলবার সঙ্গে সঙ্গে ওরাল কোশ্চেন পাশাপাশি বলে যাব। হ্যাঁ, রিলেটেড কোশ্চেন they will ask from that specimen, that related question I will mention because of the easy understanding and related question in the oral exam. So the seminoma test is, what is the counterpart test in the ovary? This is the Dysgerminoma of the ovary, is the counterpart of this thing, that is the Dysgerminoma. Incident usually 4 ticket, rarely আসে। More common হচ্ছে cryptorchidism, undescended testis is more common than normally descended testis. তাহলে কি ছোট বাচ্চা দেখবে তার প্যারেন্টসরা নিয়ে আসে undescended testis. It is very important because if we not remove from that part or not coming down in that normal position, that is vulnerable for seminoma testis or other tumor. So it is a very common undescended testis, more frequently herbal this seminoma. And this seminoma also is important because they also associated with the other component, that's why the other tumor markers can be elevated. That now the oral exam they will ask seminoma, sites of seminoma is the testis, that is the gonadal site. And other than testis, what are the extra gonadal site for seminoma or germ cell tumor they will ask. So it is in the rectoperitoneum, it is in the mediastinum, base of the brain and coccyx. They will ask in the oral that the extra gonadal site for testicular tumor or seminoma, that is orally they will ask. Now gross, how they are asked? It is a enlargement of the testis 10 times, maybe totally replaced in the testis and usually maintain the testicular site, but it is enlarged. And if it is a smaller one, it may well circumscribe to one part of that testis, and on carcation, hemorrhage means homogeneous, lobulated, multinodular or lobulated. Carcation is a bulge from that surface of the thing, and it is a grey white, yellowish in color, may have hemorrhage, and usually not present hemorrhage necrosis, but sometimes if it is a very advanced case, you can get hemorrhage and necrosis of that tumor. And usually, occasionally they inherit if it is a lead surrounding structure, that is a tunica, maybe go to the seminiferous tubules or the epididymis, mass and the scrotum. Very late when they ask the advanced case. See this thing, this is the tumor cut open, that is a lobular, that is a lobulated, yellowish to grey white in color, bulge from the carton surface, may have hemorrhage and necrosis. See this thing, this is a lobulated, this is it maintains the contour of the testis, tunica albuginea is not bleached, totally it is encircled, circumscribed. So many types of there, maybe a one part, maybe a wholly involved. So this is the seminoma, different types and different presentation, and it is due to this early stage to late stage the presentation also like that. Now microscopy, very important microscopy. তাহলে পরীক্ষার সময় তোমাদের গ্রস ফিচার জানতে হবে, মাইক্রোস্কোপি জানতে হবে। If it is a seminoma at short note, তাহলে মাইক্রোস্কোপি কি? The tumor composed of the small round cells in sheet, a lobulated pattern, in sheets and lobulated pattern, and are separated by a fibrous stromal infiltrated by small lymphocytes. These are the microscopy, and the cells are uniform in height, round to oval, with a well-defined cell border, clear to cytoplasm, usually clear, and that well-defined distinct boundary. Nucleus is polygonal, may have one or more nucleoli. Mitosis also infrequent. And the stroma is lobular characteristics is due to the presence of stroma, fibrous stroma infiltrated by the lymphocyte. So, this is the characteristic features of the cell are lobular conformation due to the presence of fibrous septa and lobule formation infiltrated by the lymphocyte. And it is clear cytoplasm because of presence of glycogen, and this EAS as its reagent positive, that is the presence of glycogen. That's why it is cut surface usually yellowish in color and give rise to a EAS positive with red color or eosinophilic in color. So this is the microscopy. So gross হয়ে গেল, microscopy হয়ে গেল। কেমন দেখতে? Here is the cell. They are stroma infiltrated by the lymphocyte and the plasma cells. These are the lobule formation of the tumor cells, may have associated with the other germ cell neoplasm and contains a different types of tumor marker with associated components of this seminoma. See this? This is the tumor cells. Near cytoplasm, these are the homogeneous round and separated by these fibrous septa with that lymphocyte infiltration. This is the characteristic features of seminoma. So, this is the thing, septa formation. Cells are polygonal to round to polygonal shaped cells. Prominent centrally placed nuclei may have 1 to 2 nucleoli, clear through eosinophilic cytoplasm, that is the PS positive, and the lymphocyte infiltration in the stroma. So, you have to write down or draw in the examination according to the marks they asked. Same thing, this is a lobulated pattern separated by the fibrous septa and the lymphocyte infiltration. Now the prognosis of the classical seminoma. Prognosis is very good than other germ cell, highly radiosensitive, and is the positive for this. You have to remember for MCQ, that is up 3/4 c-kit, but CD117, D240, placental alkaline phosphatase. These are all the microscopic genetic factors. They are positive for the classical seminoma. Prognosis is very good, highly radiosensitive. Now, clinical presentation according to the early stage to late stage, they are presented like that I told. Now, the spread. How to spread the tumor? They spread both lymphatic and hematogenous spread. Lymphatic spread, paratesticular, retroperitoneal, mediastinal and supraclavicular lymph node. So, when they start, if it is a lymphatic metastasis, so the paratesticular lymph node, pelvic lymph node metastasis, retroperitoneal, and go to the mediastinal and the supraclavicular lymph node by thoracic duct. And hematogenous to the distal metastasis at the liver, lung, vein bone, all are hematogenous site for metastasis. Now, this is the complete thing. These other tumors of this classification, no need to remember. What to remember, I will tell you. So, other tumors, namely, this is the embryonal carcinoma, very ugly looking cells or primitive cells. They may mix with other germ cells, that is the embryonal carcinoma. No need thing. That is Yorkshire tumor. Sometimes it is usually occurs in the young children, young adult. They are positive for alpha-fetoprotein, and the characteristic structure is called Schiller double body. So, MCQ for purpose, Schiller double body present in this Yorkshire tumor. Usually, or another name is endodermal sinus tumor, YST, that is the endodermal alpha-fetoprotein positive. Other tumor positive for alpha-fetoprotein is hepatocellular carcinoma. For oral purpose, you have to remember alpha-fetoprotein is a positive finding for Yorkshire tumor. Clear? Only for oral purpose, they will remember only. Next one, this is the alpha-fetoprotein positive. Yorkshire tumor, this is the Schiller double body. You know, this is the papillary structure, Schiller double body with the vessels and this papillary structure. and positive for alpha-fetoprotein. The yolk sac tumor positive for alpha-fetoprotein and yolk also for hepatocellular carcinoma. Choriocarcinoma very important, anywhere occur in both in the ovarian mode testes arising from the placental structure, that is the Situ tubercular cytomegaloblast. Choriocarcinoma, and it is positive for Beta-hCG, more than 50,000 international units. Only this thing you will remember, that is the for oral purpose. Beta-hCG, that is the choriocarcinoma, highly vascular and hematogenous metastasis, and more than 50,000 international units per liter is positive. Only that oral purpose you remember that. So this tumor composed of the Situ tuberculosis and cytomegaloblast. The tumor is considered highly vascular, highly aggressive. The thing is the Beta-hCG positive. Teratoma, for oral purpose you have to know. Tera means 3. So tumor arising from the 3 germ cell layer. So the ectoderm, endoderm, mesoderm is the 3 germ cell layer. The tumor composed of all the elements arising from the ectoderm, mesoderm and endoderm, that is the 3 germ cell layer. The theory purpose or oral purpose you have to know, that is teratoma, means 3 germ cell layer origin, and it is the mature, immature and malignant transformation. If it is a mature one, all the elements 3 germ cell layer you can get, but these are all mature, that is a mature teratoma. And immature, all the elements, these are the arising from all the germ cell layer, but immature, mostly neural element is common. And the endodermal, this is the coelomic cavity, lung epithelium, GIT, gut epithelium, or other glandular epithelium you can get. So all the components you can get. In mature teratomas, all the elements are mature, but immature elements, all the elements are immature, predominantly neural element. আরেকটা কি জানতে হবে না, এই টিউমারের টেস্টিসে unless proof otherwise testicular teratoma is immature and is malignant. তাহলে তোমার ওভারিতে যেমন ম্যাচিওর teratoma বা dermatosis is very common, is benign, but testis unless proof otherwise teratoma is immature and highly malignant and aggressive behavior. তাহলে ওরালের জন্য শুধু এইগুলো মনে রাখবে। এটা হচ্ছে ম্যাচিওর, ইমম্যাচিওর। কি কি কম্পোনেন্ট পাবো? ectodermal, skin, adnexa, eye, neural element is ectodermal origin. Mesodermal origin হচ্ছে bone, cartilage, fat, muscle, fibrous tissue, these are the mesodermal origin. And endodermal origin, GIT, respiratory epithelium, endocrine glands. That examiner will ask, what are the different 3 germ cell layer and what are the elements arising from the germ cell layer. তাহলে ওরালে এইগুলো বইতে সবসময় এগুলো পাবে না। For exam purpose, for oral purpose, you write down this thing. For oral. See this mature one? These are the cartilage, these are the cartilage, these are the fat, these are the sweat gland, mature one, all are mature one. This is the glandular epithelium, all are skin adnexa, fat, these are the element, all are mature one. So this is the mature, that is the benign condition. If it is an immature one, all elements are immature one. So testis immature teratoma is prime and this is very aggressive behavior and malignant condition. Teratoma আমি আর গেলাম না। Spermatocyte is usually prognosis is good, elderly, no need for you. Now spermatocyte is no mixed germ cells. Another thing is the seminoma is a arising from a germ cell tumor. But mixed germ cell tumor is the tumor that composed of mixed germ cell origin. So the tumor that is the seminoma with yolk sac tumor, seminoma with the embryoidal tumor, teratoma, all the mixture of the elements called the mixed germ cell tumor. So if we get a tumor in the testis, we have to find out the other elements is present or not. It is a pure germ cell or a mixed one. So mixed germ cell tumor, the testis component of that other depends upon the aggressive component of the tumor. Only to remember that only. So combination may be embryonal carcinoma, teratoma, seminoma, yolk sac tumor, so these are the combination of all the testicular tumor. Here, so it is called mixed germ cell tumor. And the clinician, they are divided the seminoma and non-seminoma because of treatment purpose. Because Seminoma, pure one is the radiosensitive, it is radioresistant. That's why prognosis is good in seminoma than non-seminoma. This is the two broad heading for clinician. Now, the clinical feature, all you know, that spread, clinical feature are told, that hematogenous spread, lymphatic spread, go to the different parts of this and tumor marker according to the composition of this thing. These are the things: LDH, Beta-hCG, Alpha-fetoprotein, CEA, human placental lactogen, testosterone, etc. All the things are depends upon the origin of this tumor marker. The clinician will help for targeted therapy. Now, staging. The tumor is composed within this testis. Is a good prognosis than the spreading from the primary to the different parts. If it is stage 1, confined to the testicular epithelium, stage 2, go to the rectoperitoneal lymph node below the diaphragm. If it is go other than this, above the diaphragm, the prognosis is poor. So it is a localized one, 99%, which is survival rate, and if it is go lymph node and rectoperitoneal other lymph node, 5 years survival rate is 96%, but still it is better for seminoma. Clear? Now, why they will ask in the short note or in the explain why seminoma is a counterpart tumor in the ovary is Dysgerminoma. Why it is counterpart? Because morphologically both tumor morphologically look like identical. If it is genetic features, these are all the chromosomal amplification at 12 is positive. Expression of pluripotent marker, that is c-KIT, RS mutation, all are same like seminoma and Dysgerminoma. That's why it is similar. One developmental origin, that is it is origin from the germ cell, and the Dysgerminoma also from the primordial germ cell. So origin, genetic factor, morphology, and microscopically also look like same. And sensitivity, it is an chemotherapy is highly sensitive. So we will ask, if they ask in the shortcut, then you have to write this thing that because of this similarity, that testicular teratoma seminoma is similar to our counterpart ovary is the Dysgerminoma. So this thing we have to remember. This thing morphologically look like same, microscopically look like the same thing. Globular configuration, stromal aligned by the small lymphocytes, same thing, and that thing is very common. So what are to take home from the testicular tumor? What is morphology, gross exhibition, microscopic exhibition. Counterpart of the seminoma is ovary. Extragonadal site for germ cell tumor, that for oral purpose you know. What are the component of the mixed germ cell tumor? Prognosis of the seminoma, tumor markers from the testicular tumor, yolk tumor, choriocarcinoma কি পাওয়া যায়, আর secondary বা metastasis হলো প্রত্যেকে আসতে পারে। These are the short thing you have to write from the oral purpose and short note purpose. Very important things commonly you can get in the outdoor, and this is really important for your MCQ short note oral question. Clear? Any question? Next, let's say carcinoma of the penis. Very often you can get in that outdoor. Important, because what are the thing you have to know will go. This is the structure, you know. This is the urethra, this is the corpus condition, this is the glans penis, this is the normal anatomical picture. We are not going in details. But what are the diseases that occur? Non-Neoplastic, Neoplastic. Non-Neoplastic, mostly common is the infection. STD, candidiasis, scabies, different types of skin diseases. We are not going phimosis, paraphimosis. Because if we go in the pediatric OPD, that patient, children, they will come with the phimosis and paraphimosis. Then the surgeon, they have to return those things or you have to circumcision of that area. So this is common thing. And another thing is the Neoplastic. Pre-invasive, invasive. Condyloma accuminatum, viral origin. Pre-malignant, that is the Penile Intraepithelial Neoplasia, that is a PEIN. Another is the infiltrating one, that is the carcinoma of the penis. Neoplastic lesion হচ্ছে পিকাসাস কি থেকে lesionটাকে বলি পিকাসাস lesion, another হচ্ছে invasive one. পিকাসাস one হচ্ছে কি না carcinoma in situ. তাহলে penile carcinoma is Situ মানে কি full thickness dysplasia chain without invading the basement membrane তাকে আমরা বলি pre-invasive, and that disease is called Erythroplasia of Queyrat. And this thing may be associated with the viral origin. If it is associated with the HPV virus, this is called the Bowen's disease. Full thickness without any invasion, that is the Bowen disease associated with HPV, and not associated with HPV, Baranitis, Xerotica, obliterans, or the lichen sclerosus atropicus. Only the nomenclature, some short notes, some MCQ they will ask, and the invasive one is called squamous cell carcinoma. So prognosis kotheke hoy associated with the HPV virus. And key virus, aggressive virus, high rates hoche HPV 16 and 18. Under 18 it is E6 E7 সবাই আমরা জানি, প্যাথোজেনিস অফ E6 E7 এর আমরা সেটাও জানি। E6 হলে কি করে inactivation of the P53 which stimulate the telomerase expression. Telomerase কি শর্ট করে দেয় longevity of the cell, কমিয়ে দেয় সাইকেল, কিন্তু টেলোমারেজ যদি ইনঅ্যাক্টিভেট করে তার আর ও বাড়তেই থাকবে। সো সেল পলিফারেশন, দিস ইজ দ্য E6। E7 এর কি কাজ? অ্যাক্ট অন দ্য আরবিজিনের উপরে কাজ করে, সেল সাইকেল ডিসরাপশন হয়, তোমার অ্যাপোপ্টোসিস কমিয়ে দেবে। সো দিস আর দ্য টু ব্রড হেডিং ফর HPV অ্যাসোসিয়েটেড উইথ দ্য 16 E6 E7 প্যাথোজেনেসিস শর্ট নোট দিলে ওইটুকু লিখলেই হয়ে যাবে। আর একটা হচ্ছে ইনভেসিভ ওয়ান, দ্যাট ইজ দ্য গিভ রাইজ টু দিস ওয়ান। তাহলে এই সবগুলো তাহলে হাই রিস্ক কি না লিডিং টু তোমার জেনেটিক ইনস্টেবিলিটি, তোমার অ্যাপোপ্টোসিস, তোমার ডিসরাপশন হয়ে যাচ্ছে, সেল ইমর্টালাইজেশন, প্রডিউস আ ইনভেসিভ স্কোয়ামাস সেল কার্সিনোমা। কাদের হয়? হচ্ছে ইউজুয়ালি ইন দ্য লো সোশিও ইকোনমিক গ্রুপ অ্যান্ড দ্য পোর তোমার social status, and it is less common in the religious purpose because that Mahavana people they have circumcision in the early age group, and because of this that stigma responsible for this squamous cell carcinoma they are not present. So these are these people who had the religious purpose circumcision, they are less vulnerable than others. So these are the Jews and Muslim people, they have very lessly affected than others. 1% malignancy elderly people have high risk হচ্ছে HPV 18, E6 and E7. Give rise to pre-invasive to invasive. This is the dysplastic change. This is a full dysplastic change without invasion, but here this is the dysplastic chain go beyond down. Why this thing? Now grossly, this is the ulcerative cauliflower-like growth. May invade the deeper structure according to the stage of the disease. See, there are various presentation. If it is here, go to the deeper structure. This is the cauliflower growth, deep infiltrating, ulcerative, going bigger in the deeper part. So various type of presentation according to the stage of the disease, maybe early stage, maybe in the late stage. Microscopically, this is the Bowen's disease. This is the intraepithelial neoplasia. This is not invading, but here from this surface epithelium go these things in the deeper structure. That is the rest of the squamous epithelial, malignant squamous epithelial cells with this keratin formation go to the deeper structure, that is invading or infiltrating squamous cell carcinoma. And these they according to the differentiation may be well differentiated, may be moderately differentiated, may be a poorly differentiated. So prognosis also depends upon the stage of the disease and their differentiation of that infiltrating squamous cell carcinoma. Now metastasis কোথায় হবে? Lymph node metastasis and distant metastasis. Lymph node metastasis is the inguinal and that pelvic grooves of lymph node, and distance go to the liver, lung, other in the late in the hematogenous spread, mostly in the lymphatic spread. Now stage 1 to stage 4 is depend upon the stage. Stage 1 in this thing without any lymph node metastasis. Stage 3 with deep infiltrating into the corona, that and the other go to the lymph node positive. If it is go to the metastasis, go to the stage 4. So according to the stage of the disease, prognosis also depend upon this. Now, how this prognosis, 5-year survival rate, no inguinal metastasis, 85 to 100%. If it is one node positive, it is 79 to 89. If it is bilateral or multiple, it is 60% prognosis. And it is an extranodal metastasis to the distal side, it is a very poor outcome. So no need to remember all those things for exam purpose. Only know this is the one entity. What is the important thing? What are the predisposing factor? That virus responsible for this pathogenesis, which cell is common, that is the squamous cell carcinoma is the more common cell of origin, and the prognosis is the depends upon the stage of the disease and lymph node metastasis. Now take home message, testicular tumor, only you know the seminoma and the classification, nutshell for oral purpose, and carcinoma of the penis in short. Seminoma, concentrate on seminoma as it may come to the specimen, and that oral purpose, short mouth purpose. Here any question, don't go any details because you don't have time. In third semester, both paper 1, paper 2, it's including 100 plus 100. Any question? So here next Wednesday we'll go to the female genital endometrial carcinoma. In short, not details for you, for completion purpose, only nutshell you have to know. Let's see. Clear?